I think we're recording. Yes. All right, take it away, Tammy. Thank you.
Okay, hi everyone. So first of all, happy Nurses Week to all our lovely, wonderful nurses. Thank you for all that you do. So I am stepping in to give this talk. I was supposed to give this talk a little bit later, but some scheduling things happened. So I am giving this talk now. This is actually a talk that I gave to my kind of small group earlier in the fall after our Movement Disorder Society meeting happened in September. So I updated it a little bit, but it's largely the same talk, but I think it will be helpful. I told Avi earlier today when we were in the operating room, if he has anything to add, he can just kind of pop in and say anything. The same thing with any of the pharmacists if they pop into the call too. So this is a talk largely about kind of movement disorder medications and treatment update. And again, if anybody has questions, just please let me know. But we will go ahead and get started. Okay, let me share my screen. Let me see if I can get it to work.
Tammy, by the way, thank you for the cookies.
Oh yeah, you're welcome, no problem. Can you guys see my presentation?
Yep, it's up.
Okay, perfect. So let's go ahead and get started. So this is a slide that I added for today's talk. So this is just, and you guys can see just the slide, right? You don't see my presenter view.
Correct. We
Okay.
can see you on the side and then yours.
Okay, perfect. So I thought it'd be nice to add this slide. This is a review about kind of Parkinson's disease drugs and kind of how they work. We will talk about some of these kind of more specifically later on in the talk, but just wanted to review kind of the mechanism of action of a lot of these things and how they kind of affect dopamine. So as you all know, so with Parkinson's disease, it is due to a relative lack of dopamine, again, with the substantia nigra in particular, again, that area of the brain kind of degrading or dying away a little bit faster. And so our mechanism in terms of treating that is usually by replacing or augmenting dopamine. So just wanted to talk a little bit about these different medications and again, how they work. And so we'll start kind of from the left side of the screen and kind of move over to the right. And so first we're going to talk about carbidopa or dopa decarboxylase inhibitors. So basically the point of carbidopa is to prevent peripheral conversion of levodopa into dopamine by inhibiting the dopa decarboxylase. So again, kind of breaking down the levodopa to regular dopamine. The reason for that is largely twofold. And so one is to try to increase the amount of levodopa that can get to across that blood-brain barrier into the brain where we need it, but also to decrease the side effects from peripheral dopamine, so largely the nausea. So as you all know, a lot of our patients, if they have nausea with their levodopa, we try to usually give them extra carbidopa to see if that will help, and that is the reason why. Moving down here, again, on the left side of the screen, so when we talk about COMT, so catechol O-methyltransferase inhibitors, that's what COMT stands for. Basically, it prevents the degradation of that levodopa into, again, something that can't cross the blood-brain barrier. So again, it kind of basically prevents or helps us have a little bit more levodopa available. And so the most common one that we all think about is entacapone, and we'll talk about some of the newer ones later. So moving across, now we're across the blood-brain barrier. So when we talk about MAO-B inhibitors, and so monoamine oxidase B inhibitors, so it basically, again, prevents the degradation of dopamine into MAO-B. And then amantadine, it's there kind of on the far kind of middle part of the screen. We actually don't really know how it works for Parkinsonism. And again, with amantadine, it used to be one of our first medications that we used to prescribe for Parkinson's. It used to be kind of a starter medication. Again, we don't really know how it works, but we think that it increases the dopamine release from presynaptic neurons and also decreases dopamine reuptake into the presynaptic neurons. So that's a little bit about that. And again, I just thought it'd be a good kind of overview. Moving on, so kind of the approach to management in terms of Parkinson's disease has kind of changed over time. People talk about it kind of being almost like a pendulum that kind of swings both ways. And so the current kind of guidelines in terms of treating Parkinson's disease is really trying to start levodopa as soon as the diagnosis is made. Levodopa is still considered the most effective treatment for relieving motor disability and dopaminergic features. This is very different from probably how people practiced even, we'll say 10 to 15 years ago. There used to be kind of this thought that you had to wait right, until things were very bad. And you only had, we'll say, X amount of good years on levodopa. So people used to generally wait and had what's called dopamine sparing strategies. And so trying to use other things, trying to use dopamine agonists. And so for a while there, and again, probably maybe even 10 years ago, dopamine agonists were very, very popular. And so people would, again, try to use as much dopamine agonists as possible as opposed to levodopa, because it was thought to perhaps, save the good years that you had on levodopa until things were worse. That being said, that has really changed. Again, Avi and I were just talking about it this morning. In my practice, I do use some agonists, but I don't use actually a ton, because there is a lot of kind of caution and almost kind of phobia with agonists these days. They are, again, particularly useful in younger patients, and particularly useful if we can get them 1 time a day dosing for people that are very active. But there's a lot of concern about side effect these days. And so the side effects are largely impulse control problems. And so again, we've had patients who have gambled their whole life savings away, people who are very compulsive, and so patients who have gotten in trouble for child pornography, for example. So a lot of those side effects are of concern. It can cause dyskinesias, can cause hallucinations, cause lower extremity edema and sleep attacks. So people are kind of just doing their day-to-day tasks, perhaps driving, and then fall asleep suddenly. And so we do get worried about those side effects. And again, it has made generally people more cautious about using agonists, particularly very high doses of agonists like we used to. So again, we used to have this kind of wait and see kind of approach to treatment. And so again, we used to say, oh, well, if you're not really bothered by it, or, oh, well, you're fine. These days, actually, studies are showing that the delay of levodopa can increase mortality. And so again, the kind of trend these days is to actually treat at the time of diagnosis. So the thought is also that dopamine replacement therapy can compensate and normalize kind of unstable basal ganglia and may help reduce metabolic stress on the surviving dopaminergic neurons. And again, particularly in patients that are over 70 years old, again, this is going to be kind of your gold standard Cadillac of medications. And so really, again, we are really emphasizing treating with levodopa very early on. So talking about levodopa, so levodopa traditionally is dosed at least 3 times a day to start. More recent evidence suggests more frequent dosing produces less pulsatile nature of levodopa given its relatively short half-life. And so it's thought maybe less dyskinesias if you dose it more frequently. One thing that I will say that I think is very important to kind of emphasize with a lot of our patients is that it is very important to give them very clear instructions of when to take medications. And so it's important to give them instructions for dosing regular intervals during the day while they're awake, right? Because the whole benefit of levodopa is to help them move better. And so it doesn't really do them much good to take short-acting Sinemet before bedtime, right? The other thing is, this is a little bit more controversial, but traditionally speaking, levodopa was supposed to be dosed like, I think 2 hours before meals, 3 hours after meals, which is a lot of the day when people can't eat if you're dosing it 3 times a day. But generally speaking, a lot of times we still advise our patients to try to take their Sinemet away from meals, largely because, again, levodopa is a protein-bound medication. And so if they have big protein meals, all of that protein in their food can absorb all of their levodopa, and then they poop out the levodopa. So generally, some people are straying away from this completely and saying, oh, well, if you don't really notice a difference, that's fine. But I try to get my patients kind of in the good habit of taking medications away from food. So there's thought to be now no additional benefit with CR dosing. Again, this is a little bit controversial. And so it's thought to have actually more erratic absorption. Again, some clinicians prefer CR dosing because they think that it is a little bit smoother in terms of less kind of dips and valleys. I get more concerned actually about kind of exacerbation of diphasic dyskinesias. And so with long-acting Sinemet, because it doesn't fully kind of come out of your system, a lot of people have kind of dose stacking and will have side effects at the end of the day, particularly dyskinesias. And for right now, there are no medications to replace levodopa in the foreseeable future. So again, this is still going to be kind of our gold standard. Moving on, so Rytary, again, this is something that you are all, I think, familiar with. Some of us use it more than others. So Rytary was FDA approved in 2015. It is basically capsules of beads of both short-acting and long-acting levodopa. With that, again, that has been, I think, something that was perhaps thought to be kind of a really big innovation, and it's been a little bit hit or miss. It is typically very hard to transition people smoothly to Rytary. There's not a good kind of conversion. So a lot of times we'll either over or underdose people, and people will either be very disconnected or very off, and it does take some titrating. Rytary is also a little bit challenging because it comes in specific sizes, and so you can't just take, you know, a half of a Rytary. And of course, you know, the Rytary comes in different sizes than regular Cinemet, and so it makes it a little bit harder to dose folks. There's also inhaled levodopa. It's also known as Inbrija is the brand name. And so it is used as a rescue, and it does reduce off symptoms. There has been some concern about tolerability and ability to administer it correctly, because again, it's kind of an inhaled version. But again, that is something that is available. So there's Duopa, and which we'll talk about that a little bit later at the end of the talk in terms of an intrajejunal infusion of levodopa that's constant. Again, some kind of comments about that. That again has also thought to be a little bit of a mixed bag. It is something that is very helpful for patients that really can't undergo kind of more surgical options like DBS. But it has had a lot of challenges. There's some challenges in terms of finding folks, in terms of surgeons and or GI docs who will put in the jejunal tube. There's a lot of issues with being able to do the cartridges for the caregivers, and a lot of issues also with that jejunal tube by itself, either again coming out or causing infection and things like that. So it has not been also as great as we thought it was going to be. Future direction, so subcutaneous levodopa. So the phase 2 study for this was actually published earlier this year, I believe in January, which demonstrated efficacy, safety, and tolerability. So they did a 28-day open label study in patients with more than 2.5 hours a day of off time. Despite, again, optimized medications, and they were either randomized to a 24-hour infusion or a 14-hour kind of waking day infusion with kind of a morning booster or morning oral dose. In terms of the safety, again, most of the side effects were infusion site reactions, nodules. There was one patient that had an abscess that developed. But they did find that, again, there was a 2-hour reduction in off time and a 3.3-hour improvement in on time with no or mild dyskinesias. So it does seem to be, again, very helpful. They are currently recruiting for the stage 3, kind of a multi-center randomized double-blind active controlled study. So that is kind of where that's at right now. Some new-ish medications, and so safinamide, this is again a mixed MAO-B inhibitor and glutamate release inhibitor. It's thought to help reduce dyskinesias, but when they looked at dyskinesias, there really wasn't a difference when compared to entacapone, which again we've had for a long time, very cheap. And so again, you know, the thought is, if it's not really that much better, do we really need it, or does it really have a place kind of in our treatment arsenal? Istradifilene, it's an adenosine A2 antagonist. It's thought to kind of attenuate hyperphosphorylation of the glutamate receptors induced by pulsatile dopaminergic stimulation. And so it's thought to reduce off time by about 0.23 hours, which is again less than entacapone, less than our MAO-B inhibitors. Again, so the thought about that is, again, if it's really not doing much, do we really need it? Opicapone, so this is a new COMT inhibitor, and it has been fairly promising, and so it's thought to be perhaps more efficacious than entacapone. It's once daily dosing, which is very nice because generally entacapone is taken with each dose of levodopa, has a really long half-life of 100 hours, which is again why it can be dosed once daily, and it has less side effects, and so no diarrhea, body fluid discoloration, or hepatotoxicity, which are side effects that we get worried about with entacapone. So again, for those who are prescribing entacapone, it is important for you to mention to the patients, oh, by the way, your sweat, your tears, your urine might all be orange, so they're not freaking out and scared. It is a common side effect, and so it's just something to counsel them about. Continuing on, so Sublingual apomorphine, very efficacious. It's the most potent non-ergot dopamine agonist, very rapid action, as efficacious as levodopa, and it's used primarily, again, as rescue for off periods. So it does reduce the UPDRS by 7.6 points at 30 minutes, and the duration of effect is about 90 minutes versus placebo. Oftentimes people will use it for early morning off periods when people feel very kind of stiff and have a difficult time kind of getting going in the morning. Again, there are subcutaneous injections. That was, again, kind of the most common form, Apoquin. And there has been inhaled formulation, but it seems that those studies have kind of stalled. So it seems like they were studying it for a little while, but it didn't seem to be something that is moving forward. Again, Avi was actually talking about a patient that he just recently prescribed sublingual apomorphine for, and apparently it worked very, very well in terms of the kind of the on period, but then there was a horrible crash in terms of the off period. And so he was mentioning that perhaps, again, that was not something that he would want to continue just because that off period was so severe and dramatic. Gocovri, and so this is our long-acting amantadine, and there has been, again, reduction in dyskinesias and reduction in motor fluctuations. Again, we were talking about this today, and so this is kind of something that is seemingly kind of hit or miss. And so I will usually, again, try regular amantadine for my patients, maximize that dose if they can tolerate it. And if there isn't any benefit, then I'll switch to Gocovri. And I've had a couple of patients who actually really like it. But again, technically, it's not much different from regular amantadine. Again, it's just a different formulation. But again, it seems like some people seem to be able to tolerate it better than short-acting amantadine. This next slide is very busy. It is a slide of basically a lot of different medications that are currently being studied. And a lot of them are kind of medications that are used for different disease states that are trying to be, again, kind of repurposed for Parkinson's disease. And so the first thing is exenatide or glucagon-like peptide agonists. So these medications are used primarily for diabetes. And so this is something that they're studying for Parkinson's disease. The study, I think, is slated to be completed in 2023. So that's, again, something that is currently being looked at. Nilotinib is a CML medication. Again, it's basically kind of a mechanism of upregulating their tyrosine kinase, c-Abl, again, for CML. And so with this, the thought is that it actually degrades misfolded alpha-synuclein and increases dopamine levels. So that's one thing. And then next, so they are, oh, and one thing, when they looked at this, when they've studied it, so far it looks like it has been safe and tolerable, but it doesn't seem to really change anything in terms of Parkinson's, in terms of symptoms. They're looking at it to see whether or not there could be a role in terms of protection or maybe, again, slowing down progression, but really in terms of the day-to-day treatment, it does not seem to be helpful. Next is disease-modifying therapy, again, kind of like our medications that we use for MS, like our rituximab or Truxima. So there are disease-modifying therapy medications, again, other MABs, so prasinezumab and cinpaminab, and that is targeting alpha-synuclein. And so far it's been a little bit mixed or even kind of negative results. And so again, that's something that is currently being looked at. Nebivolone, again, this is a cannabinoid for non-motor symptoms. Oh, sorry. Did my show go away?
Yeah, it's gone.
It's not showing.
Okay. Oh, hold on. Let me find it again. Sorry, I don't know what happened. Okay, let me go back. Is it back?
Yes.
Yes? Okay, so I was talking about nebilone. So again, it's a cannabinoid. So that is being looked at for kind of non-motor symptoms. So things like sleep, anxiety. There is some concern, and this is something that I think oftentimes we do get asked for our patients, and particularly here in Colorado, about the use of CBD or marijuana in general. But the concern oftentimes, again, at least in the long-term studies, and I think it's been kind of something that they have been also looking at for nebilone in particular, is that sometimes it can cause confusion. It can also cause orthostatic hypotension is what they were noticing, and also delusions. So not great, right, in our kind of Parkinson's population that already has those issues to begin with. So D1 specific agonists involved in cognition. And so maybe Aaron can speak a little bit more to this, but they're looking at it in terms of its role in the prefrontal cortex and whether or not I think it can do anything for cognition in particular, and not only actually in Parkinson's disease. The things that I looked at, they were also talking about it in various kind of mental health issues like schizophrenia and things like that too. Other things, anti-inflammatory, so looking actually at azathioprine, simvastatin, again, which is a statin for cholesterol, but looking at those anti-inflammatory effects also for Parkinson's disease. Istrapidine, which is a calcium channel blocker. And so they were thinking about whether or not there was kind of some antioxidant stress benefit for dopaminergic neurons. Basically, that has been a negative primary or secondary outcomes. And so they do not think that it really, again, does much for Parkinson's disease. It does not slow down any progression of Parkinson's disease either. Terazosin, again, a medication used for prostate issues. And so again, with this, they think that perhaps it could slow down Parkinson's disease progression, maybe perhaps have less complications. But again, this is something that is currently being looked at. Again, they think perhaps slowing neuronal loss also. And then genetically targeted therapies. And so again, we do have some genetic variants of Parkinson's disease. And so they're looking at kind of the idea of super precision medicine with GBA or LRRK2. So now talking briefly about surgical interventions. And so just as a reminder, in terms of folks that are being referred for DBS, these are the indications for surgical interventions, particularly for Parkinson's. So refractory tremor. So again, basically tremor that does not seem to respond to medications, because generally speaking, levodopa is not a great tremor medicine. It can be, but not always. And so tremor that does not respond to medicine, despite, again, multiple attempts at optimizing medications. Persistent motor fluctuations and or troublesome dyskinesias, again, despite medication optimization with oral regimens. And just a reminder of things that do not get better or tend to not respond to levodopa or surgical intervention. So on freezing of gait, and so a lot of patients, especially if they've had Parkinson's for a longer period of time, will have freezing that seems to happen kind of just whenever it wants to happen. It does not happen necessarily as an off symptom. Falling, dysarthria, hypophonia, balance issues, posture, dysphagia, memory, and mood. Again, generally speaking, the rule of thumb is that things that do not get better with oral levodopa will not get better with surgery. The only, again, exception to that would be refractory tremor. So again, in terms of surgical interventions, we have deep brain stimulation surgery. This is still going to be considered kind of the optimum and preferred surgical intervention. There are a lot of questions now about focused ultrasound. So we do have one focused ultrasound in the state of Colorado in Boulder, at Boulder Memorial, but also the university is talking about getting a focused ultrasound, and I think Swedish is also talking about that. The indication right now, and again, I think I have another slide about it, but the focused ultrasound right now is really only approved for unilateral essential tremor. And so that is, again, a question that we are getting often. And so if you have a Parkinson's patient who's asking about focused ultrasound, again, that is not currently approved. So again, we did talk about the intestinal levodopa infusion, or DUOPA. Again, it is a PEG jejunal tube. Again, it does reduce off time without troublesome dyskinesias compared to oral levodopa, because again, it is a constant infusion. Again, very difficult to manage, as well as a lot of GI complications. It is very clunky. Also, it's big. And so oftentimes, if you have patients that are actually still very active, it is something that's very hard to manage. Generally speaking, again, DUOPA is for patients that are either too sick or sometimes too cognitively impaired to undergo DBS. And so that is kind of the one of the main kind of indications for DUOPA. Again, generally speaking, most institutions will have, again, maybe a handful of patients on DUOPA. It has not been kind of the saving grace, if you will, that I think people thought it was going to be. And again, we also talked about the subcutaneous apomorphine infusion. So this next slide just kind of gives a kind of good summary about things that we can and can't do, things that are limitations for each of those surgical interventions. And so for anybody having, again, marked ongoing hallucinations, psychosis, again, DBS is not going to be great. The apomorphine infusion is also not going to be great. So again, this is kind of that population that we were just talking about for the DUOPA, a little bit safer. People who have impulse control disorders, again, not really great for any kind of surgical intervention, maybe DBS, but even with that, generally speaking, we are not real keen to take those folks to DBS. Mild cognitive impairment, again, with that is kind of that middle ground where people usually are fine, again, with any of these kind of surgical interventions. Moderate dementia, again, perhaps the DUOPA as opposed to, again, DBS, which can sometimes worsen cognition. Pronounced depression, again, not great for DBS, sometimes again for the other interventions. Drug-related daytime somnolence, again, maybe kind of, DBS and levodopa infusion, DBS in particular, because maybe again, if we do STN stimulation, we can lower their amount of medication that they take. Not great for, again, apomorphine because of the concern about sleep attacks and as a dopamine agonist. And then again, generally things that are levodopa unresponsive, postural gait issues, falls, none of it, again, is really going to be great. None of those things are probably going to help those symptoms in particular. So if a patient really is coming to you and saying, hey, I have falls all the time, I really want to get DBS, again, that is not a great indication for any of these surgical interventions. All of these things, more so, again, DBS than probably some of the others, do help with patient independence. Again, DBS can really improve people's quality of life in terms of their symptom management as a whole, dependence on medications, things like that. And all of these things are technically reversible. And technically, again, there's not really a limitation for any of these treatments with age. With DBS, again, as you get older, obviously you are usually more medically complicated, sicker, usually more frail. And so, that sometimes can be a limitation in terms of surgery. That being said, again, when I was in fellowship, we took a 93-year-old or something to DBS, again, for essential tremor, but again, still is not a hard and fast rule in terms of age cutoffs. Next, in terms of DBS advances, and so the kind of most recent kind of changes that have happened even in the last, we'll say 5 or 6 years, is going from quadrupolar ring electrodes versus segmented or directional electrodes. And so basically the new kind of segmented or directional electrodes allow us to kind of steer our stimulation and settings towards benefits and basically away from adverse side effects. For a long time there, we probably only had one company for a long time, Medtronic, for, we'll say 20 to 30 years. And then recently, St. Jude and Abbott has come out with a system, and Boston Scientific has also come out with a system. Here at Kaiser, we are currently only doing 2 systems with the plan of integrating Boston Scientific here in the near future. This does kind of bring up programming complexity. So again, going from, just 4 rings where you basically, just pick which contacts you want to stimulate versus going to 65 contact combinations, 13,000 other programming combinations versus millions of combinations, again, with these new segmented rings that have a lot more contacts. So it does make it hard because generally speaking, a lot of times with DBS, we are starting with kind of basic programming, but a lot of it is really what they call hunt and peck, right? We kind of pick a setting, see if it works, try this, try that, see if that works. There's not really, again, a great way for us to know what the kind of ideal settings is for anybody, but that is, again, something that we are working on in terms of future directions. So there is something, again, we're working towards computer modeling, kind of learning and programming, patient-specific neural activation and prediction maps to suggest optimal programming. And the thing that is kind of in the works the most is kind of this idea of adaptive neurostimulation and kind of sensing technology with the possibility of a closed loop simulation. So right now we are able to have the sensing technology. And so those are in the newest kind of forms of our DBS IPG or battery with the electrodes. And so we're able to sense, but right now that's all we can do. We can record and kind of see what's happening. But the idea is at some point when we get the technology right, people will be able to, or the device itself will be able to sense when a patient is going to have a tremor or when they're going to perhaps be off. And then real time, the system will be able to adapt to that. Kind of like NeuroPace, sort of, but we are not quite there yet. And the other thing that we are working towards, which again is now becoming a really real reality, is remote programming, kind of like people are able to do for pacemakers. So that is kind of where we're going there. So moving forward to high frequency focused ultrasound. So again, this is MRI guided, it is real time, it is lesional. So again, what happens is they basically take an ultrasound and burn a hole in your brain. It is, again, right now only unilateral for essential tremor. Again, that is the only indication that has been approved. There's this kind of idea that it is non-invasive versus kind of non-incisional. So again, we have talked about this recently, and really it is fairly actually invasive. So they do still get their whole head shaved, which generally speaking for DBS, we can either do very thin strips of their hair that is shaved, or again, some people will shave at least just half of their head. You are still put in a frame, and from what I understand, it is very uncomfortable. So a lot of patients are complaining about how uncomfortable it really is, because basically, it, you know, like I said, you're using an ultrasound to burn a hole in the brain, so it gets really hot. They're trying to, I guess, bathe the patient's head in cold water the whole time to try again to keep the temperature down on their skin. So again, people have this idea, oh, it's just an ultrasound, and again, it's non-invasive, and oh, you don't have to get surgery, but it is still a pretty big deal. And so again, generally speaking, there is probably a subset of patients that would really benefit from this, and it does work very well. But the difficult thing about focused ultrasound, at least right now, is that we don't have any ability to adjust, right, as people change, or as their tremor or as their Parkinson's may progress. And so that is something that has been kind of a limitation of focused ultrasound. Future directions for focused ultrasound, including bilateral essential tremor, right? So right now it's, again, just unilateral essential tremor, of course, for Parkinson's disease. And the last time, again, at MDS, they were talking about using focused ultrasound as a way to kind of open the blood-brain barrier with low frequency focused ultrasound as a way to actually deliver medications or treatments. So that is kind of the direction of focused ultrasound. Again, it is fairly popular in terms of, again, a lot of patients really asking about it and wondering about it, but in reality, I think it's a smaller group of people that actually would benefit from this. I think that's all I have. Again, it was a fairly short presentation. Does anybody have questions?
That was great, Tammy. Thank you.
That was a lot.
Thank you.
Fast.
I guess, kind of a easy, or I don't know, I'm so new to prescribing all these medications, but, when you have after I prescribe Cinemet and I need to then add to that, like, how do I decide, oh, this is such an easy question, but not for me. Like, how do I decide what I add? You know, like if someone needs more,
Yeah.
how do you decide if you go to entacapone or you go to a dopamine agonist? Like, can you kind of walk me through how you make that decision?
Yeah, I think it largely depends on what their issue is in the patient, right? Which is such a generic answer. But so, for example, if it was like a 75-year-old that was having motor fluctuations, like I probably wouldn't add an agonist, right? Because they're so old, I'd be worried about all those side effects. And if somebody said to me, yeah, you know, my levodopa seems to work, but it wears off maybe 30 minutes, you know, before the next dose, then that would be kind of a role for entacapone or opicapone even. So generally speaking, again, entacapone and opicapone, a little bit different, but entacapone in particular is thought to give you maybe about 30 minutes of additional on time. So it's again a booster, right, to kind of help it last a little bit longer. But if they're saying, hey, you know, I never really feel like I am loose enough, or I feel like I, you know, have maybe a little bit reduction in my tremor, but not enough, you know, then you really want to increase that levodopa. So, like I said, I think it largely depends. In terms of medications like rasagiline or sledgiline, again, those are maybe thought perhaps to give a little bit more on time, but generally speaking, they are fairly mild in terms of benefit and in terms of side effects. So people used to give, again, rasagiline in particular or sledgiline because they thought it was protective, but these days, again, that has been shown to be pretty much a wash. And so there's not a huge role for that unless it's a medication that sometimes we'll start on people that are very hesitant to start medication because at least you're kind of on something. But generally speaking, it's not going to give you a whole lot of motor relief, if you will.
So like in a younger patient who, you know, needs more, then you could add an agonist.
Yep. And here at Kaiser, generally the short-acting agonists are formulary. So usually, again, that's going to be dosed 3 times a day. Sometimes, again, we can get the long-acting agonists covered if people have either side effects, but not just for like the sake of convenience, which is really kind of one of the benefits of long-acting agonists, kind of in the non-Kaiser world is like, hey, you can take this medication once a day and not have to worry about taking it throughout the day for somebody who's very young, very active. But again, at Kaiser, we generally have to use the short-acting agonist first. But agonists, again, in a younger person who, again, does not have issues with compulsive behavior, obsessive, you know, behavior or anything like that, again, would be really appropriate to add there too. Avi, do you have anything to say about medication, I guess, regimen strategies?
No, I mean, I think, you know, the most important thing that I always discuss with patients is one is when you take carbidopa, levodopa, is it strong enough? And then also, is it going to last long enough to get you to the next dose? And depending on that answer, that's kind of what guides your next therapy. And usually, you know, I'll just try to optimize things as best I can with carbidopa, levodopa, and I'll try to go to 4 times a day. If patients are okay with taking a regimen 5 times a day, then I would typically do that before I would add another medication. But if that burden starts to become a lot larger for patients, then that's when I would start to look at entacapone or look at some of the other medications to help, so they're not having to take medications 5 or 6 times a day as that gets more and more bothersome to them.
And that's why it's so important, I think, to really educate patients in terms of how to take the levodopa, because if they're taking it 2 hours apart and then 8 hours apart and then 4 hours apart, you know, it makes it really hard to really try to manage their medications. But if they're taking it at really even intervals, say, like, again, I usually start my patients on something like 7, 12, and 5. And if they can routinely say, hey, my medication always wears off an hour before my next dose, that helps us know, again, you either need more, right, in terms of the amount, or you need to change the frequency in terms of, you know, shortening the interval between. So that's why it's really helpful. And then when you do run into patients who say, like, oh, I don't think my medication really works, that's kind of when you want to start saying, oh, are you doing it with food? Are you not doing it with food? Because again, it may be just because they need more medicine, but if it is a factor of whether or not they're taking it with food, again, you don't want it to be that the medication's not already optimized and say, well, you know, it's because we need more. You know, and so I think that's why it's really helpful to really try to get them in kind of a good habit to begin with. But oftentimes, again, it's hard because, you know, the beginning they're overwhelmed and, you know, just trying to take the medication as they can. So I think that's kind of, I agree. I usually try to optimize levodopa and do it as much as possible. But to give you an idea, again, you know, we have patients that take levodopa like 2 tablets every hour and a half or 2 hours, you know? And so obviously that's a lot of time and that's a lot of your life kind of dedicated to taking medicines, but again, it happens. And so there's no, and the other question that we get all the time is there a maximum dose of levodopa? And there's not, right? Even though, you know, things pop up in the computer saying like, are you sure you want to give this much? I'm like, yeah, it's fine. But generally speaking, it's mostly just going to be based on tolerability, right? In terms of side effects. And so if people obviously, you know, can't take more than a tablet and a half because they have dyskinesias that are very bothersome to them, then, you know, that obviously limits how much you can give. And another, I guess, aside about dyskinesia, generally speaking, dyskinesias do not need to be treated unless they are bothersome to the patient in any kind of way, right? So for some people, maybe it's embarrassing to them. For some people, maybe it's uncomfortable. Maybe they have pain with them. If they are having serious injuries from dyskinesias, right? So if they fall or something like that. Or the third indication would be probably if they basically are losing weight, like they can't calorically keep up with, you know, how many calories they're burning because they're so dyskinetic. That would be another indication. Generally speaking, a lot of times dyskinesias are not bothersome to patients. It's more bothersome to families. So you have wives come in and be like, why is my husband, you know, shaking and twisting all over the place, you know, and patients, generally speaking, are not particularly bothered by it because oftentimes they're on or peak dose dyskinesias. And so they feel good, right? They're like, oh, I don't have stiffness and I can move and I don't really mind them. And so generally speaking, you don't have to treat dyskinesias just to treat them for the sake of treating them, if that makes sense. Lindsay had a question about weaning dopamine agonists when people are having impulse or compulsive problems. So it's a good question. So generally speaking, especially if people have been on agonists for a long time, you do need to wean them very slowly because people will have withdrawal from their agonists. They just kind of feel like crap. And so you should wean them very slowly. So I had a patient that I just saw yesterday that had been on pramipexole 1.5 milligrams 3 times a day for a couple of years. And so with that, we went down from 1.5 to 1.25, right? And we're going to do that for a little while and kind of see. But oftentimes, depending on kind of how they look on their exam, Lindsay, you can kind of gauge whether or not you think that they need to be cross-titrated. So again, anytime that you are taking away medicine, again, if they're already looking a little bit off, they're going to be more off, right? If we take away more medicine. So you do generally need to increase their levodopa. Either, again, start them on levodopa if they're not already on it or increase their dose a little bit. Or what I do oftentimes with my patients is say like, okay, we'll come down, but if you feel bad, you let me know, and then we'll make a medication change. But oftentimes there does need to be kind of a cross-titration as people are coming down. Other questions in general? Bobby, anything you want to add in terms of meds or things?
I don't think there's a lot to add. I think you did a really good job, really comprehensive, discussed all the major kind of developments and movement disorders. So yeah, I don't have a lot to add right now.
Thanks. So yeah, like I said, I know that was a ton and it was fast, but we'll make the slides available for everybody so that you can see them. Again, generally speaking, even though it sounds like there's a lot, there's not really a lot, you know, in terms of different options and things that are readily available. Some of these things are, you know, going to be kind of coming in the pipe work and things like that. But oftentimes, obviously, if you have questions or need help, feel free to send them to me or Avi, or, you know, just send us a chart and we can review it. Yeah, so there is not that much. And the nice thing is, generally speaking, these medications are fairly safe. You know, people will have nausea and people may have side effects, but they're not going to be life-threatening side effects, which is nice.
Well, thank you. That was a really great talk.
Yeah, no problem. So if we don't have any other questions, do we want to end early, or is there anything else that we need to talk about?
I think we can get everybody back some time at the end of the day. So
I just had a reminder from UBT So for the providers, I know it can be hard kind of with the day, starting and things getting crazy, but if you do have the time, please try to make it a point to meet with your rooming staff and just kind of run through your schedule for the day to try to see if there's anything special that patients may need, or if you anticipate anything that might be a challenge. And then also to try to check in with your rooming staff to see, hey, is your day looking pretty crazy now? Or hey, if I need this special thing, is this something that we can do today versus sometime in the future? So just a reminder to try to do that if you have time. Oh, Bridget has a question about DBS MRI stuff. Was there something in particular, Bridget, about that, or?
Tammy, it must be the project.
Yes, so it is in the works currently. We just talked about it, and I wrote something up the other day, and it is going to be hopefully finalized here soon. So we will talk about it and have something finalized for the staff, hopefully sooner rather than later. But yes, that is being finalized, and yes, to also, I guess, extrapolate that, almost all of the DBS that we have now is going to be fully MRI compatible, which is nice, except for the new one, Boston Scientific, but they are working on it from what I understand.
Tammy, make sure you show me beforehand, because I had a conversation with medical imaging, and there's a process, like there's a step in the process that we have to make sure it aligns with them.
Right, yes, we are. Don't worry, we will run it by you before anything gets sent to the staff and everybody else. And so I think everybody has to kind of bless it, I think, before it's finalized.
Thank you.
Mm-hmm. Other questions, concerns? Okay. Well, I guess everybody have a good rest of the day. Let me know if you have any questions.